Hi, everyone who is entering the room now. My name's Lucy Giles. I'm a practice consultant for SafeLives. As you are joining the room, you will see, for those of you who are familiar with Mentimeter, if you have your phones on you, you can go to www.menti.com or our Fab Tech team will put the link in the chat, or you can use the QR code with your phone and it'll take you to Mentimeter. And you can put in, I'm just going to, because I can't see it, you can put in the code 8826583. And all we're going to do is for you to think about one question as you're coming into the room with, when you hear the term older people, what are the first words you think of? So we've got a good 5 minutes. Thank you for joining today, and hopefully you will find it very beneficial and sharing of practice. So yeah, if you can start putting that in, and then we will see what stuff comes up. If you have any problems with the link or stuff, then if you can just write in the chat and somebody will hopefully help you out. Nicola has raised her hand. Yeah, so there's 3 ways of doing it. You can go into your phone and just Google www.menti.com and use that code, or there'll be a link in the chat that you can go straight to. Or you can photograph the QR code, which will take you to it. And you can just literally start typing in your words. Stop sharing. Oh, brilliant. Okay, that's really interesting that vulnerable is one of the kind of the biggest words, and frail. And actually, we'll talk about that terminology a little bit later on. That's amazing. Thank you. Lived experience. We will definitely be talking about that, especially towards the end of the session. Experience. That's really, really nice. I was at a conference at the weekend and some people spoke and they talked about very much as elders, whereas I think sometimes in other communities we don't necessarily use positive words like that. Wise, definitely. Underestimated, totally. These are amazing. This is fantastic. Thank you. Brilliant. So yes, so for people who are just might be coming in now, we're just doing a quick Mentimeter for 5 minutes. If people can Google www.menti.com and use the code 8826583, or go to the link in the chat, and it'll take you to the question, what are the first words you think of when you say old? When I say older people, elderly. That's brilliant. Lonely, yep. And we'll talk about things like the pandemic, which have added to that. Overlooked. Grandparents. Fabulous. Yes, isolated is coming up a lot. Invisible. Retired. It's interesting, but vulnerable is definitely the one that's remaining the strongest. Respect, yes, absolutely. Yep, dementia, and we will touch on that. Great. For those of you that are still joining, we're doing a quick Mentimeter to begin with. So if people want to Google on their phones, www.menti.com, and use the code 88265583, or go to the link in the chat and have a think about what the first words are you think of when I say older people. Fragile, forgotten's coming up a lot, misunderstood, definitely. Knowledge, it's a big one. Okay, so we'll put a stop to there. Thank you very much. I'm just going to go back to sharing my screen. Brilliant. Thank you for doing that. That was that looked really good. So I'm now going to hand over to do the introduction to the webinar this morning to my colleague Nikki Kelly, who is head of practice here at the practice team at SafeLives. Over to you, Nikki.
Thank you and welcome everybody. And it's an interesting way to start, isn't it? Because as a nan, I now start to think of myself as becoming an older person. And at the same time, I've recently supported an uncle who developed frontal lobe dementia at 83 and had started to go into an end of life scenario. And then I've got elderly parents that are, touch wood, still very active at 80. So it can mean so many things in so many different scenarios as we kind of get older ourselves, and maybe what we also come into contact with personally or professionally, and how all of those experiences feed into our understanding and how we support older people more effectively together. So I'm just going to go through the agenda. Data is, Lucy's going to talk to some of our data and data around older adults, barriers and challenges to accessing the right supports. We're going to have a quick comfort break, and then we'll go into domestic homicide reviews and MARAC. What does that actually mean in practice, and what are we seeing on the ground through all the work that we're also doing through our public health approach? And then we're going to have some questions and a chance for you to have a chat at the end. And just in terms of a quick reminder, we are recording today's webinar except the Q&A. So this will also be available on YouTube with details all emailed out to you, along with the slides and any additional resources within 2 weeks. The speakers can be seen. Attendees have cameras and mics that are disabled. Please be respectful in the chat. You can turn on captions using the captions button at the bottom of your screen. Please use the chat box as much as possible. We want it to be really interactive. And if we can't answer them today, we'll definitely come back when we provide all of the feedback and the links to the YouTube, etc. And just to recognise that there will be survivors attending the webinar as well today. And we would always encourage people to do what they need to do for their own safety and well-being. And also, if you've got any local links or any people that you reach out to if you need them, obviously please use them as and when you need to. Thank you. Next slide, please. So just very briefly, as an introduction to what we're doing in the practice team, we, for the last 2.5, 3 years now, have been looking at a public health approach to domestic abuse and working alongside 40 local areas at the moment, looking at the whole picture on the ground. So the person, the family, the whole community, and what does that actually mean when we're looking at that through the lens of voice data practice in a local system. We're just about to launch our exec summary on March the 7th, and then there'll be a full report. So if anyone is interested in receiving those links, we can always send that out to you at a later date as well. Next slide, please. And over to you, Lucy.
Thank you very much, Nikki. Okay, so I am going to begin with looking at some of the data and prevalence around older people and domestic abuse. What I will start by saying is about sort of 5-6 years ago, we did a quite considerable amount of work around older people, and we have built on some of that work over the years. But what this webinar will end on is that we are at SafeLives, and hopefully with expert partners and authentic voice pioneers, is to actually do the second stage of that work. So that's something at the end we'll also be asking ideally what you would like to see. So I'm going to go through just some sort of general data, and then we will look at barriers and challenges. So still, I think it's always good to remind people, especially for those who maybe aren't directly in the domestic abuse field, that still around 2 million people suffer from domestic abuse in England and Wales, and that remains 7.5% of the population women and 4.3% of the population of men. And that I think it's important to remember that 2 women a week still die at the hands of their partner or ex-partner, and that is significant when we talk around differences around older people a bit later on. And 85% of victims still have made 5 attempts on average to get support from professionals in the year before they accessed effective help to stop the abuse. And that is very prevalent around older people, because actually that number is much, much higher. And then, interesting enough, we've added this back in because when we started this work about 5 years ago, amazingly, the Office of National Statistics did not take any data for those over 60. That changed about 4 or 5 years ago, which was really good. Although at the time it changed bizarrely, it was 60 to into mid 70s. It now recently went up to 60 plus. So that's really good. But I think it is also quite indicative of how we often view older people, that, you know, clearly there's that kind of subconscious way of looking at older people, is they clearly can't suffer these particular things because they're old. So you almost kind of push them out of existence. And that was kind of some of the words that were coming up on the Mentimeter. And SafeLives estimates that approximately 120,000 individuals aged 65 plus have experienced at least one form of abuse, and that's psychological, physical, sexual, financial. What is quite interesting, and I suppose simultaneously slightly depressing, is that since when we started that work around the spotlights, and at the end, my lovely colleague Lauren is going to put the link to the spotlights work, is that actually that hasn't increased much in terms of gathering that data. So actually now we kind of know that that is much, much higher, and hopefully the work we're going to begin will start to reflect that. Some of the next data findings is from our IDFA data set. So that's the Independent Domestic Violence Advisor. So so what's quite pertinent to say here is that this is data from those older people over 61 that are actually accessing domestic abuse services. And actually less people who are, the older the person, the less likely they are to access those services. So again, this is just a very, very small cohort of people. So if you think only 4% of people are accessing that services, that actually in real life, we need to be much better at not only identifying older people who are experiencing domestic abuse, but also better at engaging them into our services, making them want to come to our services, but more importantly, not just having the focus on IDFA and specialist domestic abuse services doing that. It needs to be, especially with older people, the responsibility of other agencies and statutory agencies, and I'll mention that a bit more. While older clients are slightly less high risk than those under 60 and experience predominantly moderate forms of abuse, they suffer abuse for much longer. And this suggests that older clients living with abuse for long periods before they help they need. What I will say, so this is a really interesting strapline in a way, because I think sometimes people can think, oh, that's a bit odd because they're experiencing moderate forms of abuse. They do suffer high risk abuse, but one of the bits of this data kind of recognizes is that what gets missed is escalation. So when you kind of look at domestic homicide reviews, that actually one of the biggest themes for older people, that the threshold of escalating abuse, which is high risk in itself, is missed time and time again. So what is less likely as older people is that you get a crisis point where a huge incident happens, but it'll be slow, insidious forms of repeating incident, which will escalate in frequency. And often as agencies, we still look at incidents in silos in terms of a lack of coordination with other services. And often what we don't look at is an overall what's actually happening. So we look at it as individual things, if that makes sense. Even though older clients experience abuse for much longer, they receive support for a shorter period of time. That's just an interesting bit of data, because actually nobody really knows why that is. However, as I'm sure many people on the webinar will agree, it's really important that we look at the kind of services that we're offering to older people, and are they the right sort of services, because it might be one of the reasons that people disengage. And further analysis shows a large variability, with 25% of cases having a length of 2 years or less, while 25% having much longer, 20 to 50 years, which is quite a kind of difference in timeline. And this, and I apologize, I've just realized I've forgotten to change this slide, is that, although slightly depressingly, has only increased slightly. So at the time this was done, only 0.7% of cases were heard at Marriott were referred by adult social care or safeguarding. That has actually increased to 0.8. So it is getting slightly better, but we expect that to really be much higher. And for those of you in the room that don't know what MARIC is, it's the Multi-Agency Risk Assessment Conference, where people are identified at high risk, get referred, get a SafeLives RIC completed, a service from an IDVA, and then an action plan, safety plan from the MARIC. So I think you would agree that this is quite high. 80% of older adults are not visible to services, and that's mainly domestic abuse services, which is phenomenal high. And I would say probably that is high now. Of those visible to services, a quarter live with abuse for more than 20 years. And again, I think that's probably higher in reality. Interestingly, older clients are more likely to be referred through the police when they are identified at crisis point. So if you kind of think back to what I was just saying, that actually if we were identifying older people generally more effectively, we would be identifying them prior to that crisis point, but it would be reaching crisis points another way, through escalation. Older clients are less likely to self-refer, and usually it is either, like I say, the crisis point through the police or through a neighbour. So that's more common than in younger people or people under 40 experiencing domestic abuse, that actually neighbours are more likely to report. This is, I think, really interesting, and this is one that is debated more and more now, and that's really, really good. And hopefully this will be some of the work that SafeLives with partners will be taking forward. So the majority of older clients are female, as we would expect, because domestic abuse remains a gendered crime. However, data shows that there are much higher proportions of older men experiencing abuse. And that's really kind of significant, because again, when people are looking to identify or asking people to disclose, from the data, it kind of suggests that services need to be more aware that the victim may well be the male. Having said that, there's caveats around all of that, as always, is that within that, there may be issues around dementia, Alzheimer's, kind of organic kind of mental health issues that blur the lines of the victim and perpetrator as well. And often, in terms of kind of practice, people delivering practice often see situations whereby the perpetrator and victim change. So it might be that a survivor has experienced abuse from the perpetrator for 20 years, 30 years, and then with the aging process, the perpetrator becomes immobile, has a disability, has Alzheimer's or dementia, and so becomes a much more fragile person, and therefore the survivor sort of feels that they then have taken back the power, and almost kind of starts to sort of take revenge from the years of abuse. So that is seen in services on quite frequent levels. So I guess with that, I'm sort of saying, you know, it's really, really interesting, and it kind of gets us into that debate about whether something is dementia or Alzheimer's or domestic abuse. Also, 35% of male victims, again, had a female abuser, but also over half of male victims were abused by an adult family member. And again, that just kind of, you will get these slides, sort of reiterates more of that the data around kind of gender. The other thing that's quite important here is that perpetrators of abuse against those who are older were less likely to have a previous criminal record. And I think for those of you that work in the domestic abuse field, or those of you that attend Marriott frequently, it's really interesting because often it's very easy for professionals to feel that they have more control over how they can work with someone if someone's had a criminal record. So often in the Marriott arena, if someone has had no criminal history or no criminal justice intervention, often partner agencies can feel a little bit, I suppose, lacking in confidence because the police are less likely to intervene. I think what it also does, as we saw in the Mentimeter when we kind of looked at words around stereotype, it can stereotype. So often, especially it can happen in health services where people will see the perpetrator, especially male, as, well, I can't believe they would behave like that because they're, you know, a very sweet little old man, and we've heard language around that. So I do think there is that stereotype that people expect perpetrators to have always had some sort of criminal justice intervention or attempted intervention or history at some point. And often with older perpetrators, that isn't there. So professionals really need to kind of look at, actually doesn't mean that they're not perpetrated. I won't repeat this, but also the bottom stat is also, it's very similar to male victims. So around half of female perpetrators are adult family members of the victim. This is really relevant because often when services or professionals are working with supporting people or wanting to encourage people to disclose domestic abuse, I think people traditionally, unless people are very, very specialized, people traditionally tend to look for the partner situation and a current partner or ex-partner. Whereas when people are working with people over 61, professionals really need to be thinking about, A, the abuser might not be the partner or ex-partner. It is more likely or as likely to be a family member, and it is more likely to be more than one family member. So people really need to think outside of the box. There's still, even though with the new Domestic Abuse Act and the new statutory definition, there is still can be a lot of kind of blurred lines around what domestic abuse is. And I know when we have done case auditing with the police in the past around older people, and we've looked at cases, for example, with siblings or with grandchildren to grandparents, the police will automatically not work with that as domestic abuse because they don't see it as domestic abuse when it is. So we need to be looking at those familial relationships as well. That's just some more data. I won't go through that. This you would sort of expect. So in terms of living together, people who are older are much more likely to be living together while the abuse is happening, whereas people under 40 are less likely. And older clients experience abuse from an average of 12.9 years before accessing help, and they are less likely to leave the perpetrator of the abuse as well. That doesn't mean that it doesn't happen, and there are kind of plenty of stories, especially from the Older People's Commission in Wales, where actually people who have made those huge changes in their 70s and 80s, which is just phenomenal. And I advise you to look on their website from some of the amazing work that they have done. So older clients, when we look at sort of dependency issues, older clients have a lower level of complex needs in terms of mental health and substance misuse, but are much more likely to have a disability and dependency issue. And as you can see, and I guess as some of you might expect, I mean, that leap is huge. It's absolutely phenomenal, 48% to 13%. One of the things I just want to add as a caveat, and which might seem a bit weird because it's our data, but I want to add a huge, I guess, anecdotal caveat to that. When we say lower level of complex needs, a word I hate, but I'm saying it, I would suggest that if there were a lot of research, and I think there are bits of research coming out now, that if someone did studies on older people, especially older women, and using alcohol use in later age, I think those numbers would rise. I think, again, it's an untapped bit of data we don't have. I think there's, especially since COVID, there's kind of recognition that that sort of abuse may be happening, especially as it can often be behind closed doors. So I would take that first bit as a little, with a little bit pinch of salt. Older victims are less likely to attempt to leave in the year before accessing help. And And also there can be, in terms of the outcomes from IDFA service, in terms of reduction in each abuse type when they left the service, that there was a less, things like sexual abuse and physical abuse and harassment, stalking, jealousy and cruel behaviour were pretty similar to those under 60, but they were they were reported in a low way. So basically, what that shows is that I think 61% plus are reporting less levels, but they think that's because there's less reporting, if that makes sense. And also, I would say that even though sexual abuse between older people, that's a low statistic, 56, that all ties in with barriers. And actually, it's not that it's not happening, it's that people aren't talking about it. And often that is something that kind of old generations feel much, not all older generation, but feel kind of less comfortable talking about as well. So in terms of findings from our leading lights service using our insights, which is our data that looks at IDFA services. So 1 in 3 of the victims were abused by an intimate partner, and the same percentage by an adult family member. So if I ask you to only take one thing away today, that with older people, people really have to shift away from that one intimate partner or ex-partner. And some of this, so 16% were being abused by multiple perpetrators. So that's kind of more than one, which I think is quite frightening. So that's just some more of the data. And again, I'll just pick some of those things out. 1 in 5 of perpetrators were female. We've already spoken about that. That's really interesting. And there was criminal justice supported 1 out of 3 cases, and only a small number resulted in charges. And if you, charges anyway, generally, which hopefully is shifting slowly, is very, very difficult for all ages of people experiencing domestic abuse, that actually it was really, really small. So that's the kind of work we need to do in terms of improving that. And only 5% of clients were supported in obtaining civil injunction. So that's very, very low in comparison to people under 60. I want to just mention this policy report, which is still used today. It's now about kind of 5 years old, but we still probably get asked about it more than a lot of our policy reports. And it was written, it's called Cry for Health. And it was a recognition that healthcare, so either primary healthcare or hospitals, had such a significant part to play in identifying and working with older people, because as we've already seen, older people are much less likely to engage with domestic abuse services and the police. And with older people, there needs to be that less reliant on those 2 services. And we do sometimes still see that, even though we see brilliant work with partner agencies, but often around the merit table, we will still see most of the emphasis being put on IDFA doing something and police, whereas actually with older people, it needs to be health, it needs to be adult social care, it needs to be adult safeguarding that are kind of picking up that role as well, and working with those experts. So the recommendations were around having IDFA services within healthcare settings. Hospital services are significantly more likely to have older people as clients, and 50 plus clients at the age group account for 14% of the hospital IDFA clients, but only 10% of local IDFA clients. So that difference is significant. So that's why it's really, really important to try and encourage your local sort of commissioners to look at that. And 60 plus clients account for 5% of hospital IDFA clients, but only 3% of local IDFA clients. So again, that is quite big. And 65 plus age group clients account for 4% of hospital IDFA clients. So that is quite high. Since that report was written, there has been an increase in those roles being commissioned in hospitals, which is absolutely fantastic. So if anyone wants access to that, I'm going to ask Lauren to put that in the chat, the link to that, but hopefully it will keep on increasing. So I just want to look at particular data around disability, which obviously links to older people, because the chance of people having disability issues is much, much higher. So disabled women are twice as likely to experience domestic abuse than non-disabled women. And disabled women experience more frequent and severe abuse over longer periods of time, which is, which is pretty horrific. And disabled victims are more likely to be suffering abuse from a current partner than non-disabled victims. So I guess that's another sort of element on top, that if somebody is disabled and older, it might be that the current partner will be one of those abusers. And disabled victims are more than twice as likely to be experiencing abuse from an adult family member, again, a non-disabled client. So again, it's looking at, Nikki at the beginning talked about the public health work around the whole family and the whole picture, and this kind of resonates with the work hopefully we're going to be doing around older people, because it really is looking at the whole kind of family around that person and getting the relevant agencies in to support them. The other thing, sorry, I just want to go back to that. The other thing that we will be hopefully looking into around that is around kind of different cohorts of diverse communities. So when there's definitely kind of research around, if you're looking at LGBT plus clients, that actually, especially around women's same-sex partners, that disability and older victims is a really, again, sort of untouched bit of research, and definitely really, really hidden cohorts of people. And also the amazing Jewish Choices up in West Wales, who work hand with Aberystwyth University, have done some absolutely phenomenal work around LGBT plus and older people and domestic abuse. So, and they were a huge expert partner with us when we started the older work, and that continued to be so. I just wanted to add this in the spotlights. We had a lot of kind of survivor feedback, but I just wanted to kind of pick out this stuff from the amazing Deaf Hope. They are an organisation in London. They are phenomenal, and some of their survivors spoke about or talked about their abuse experienced by them feels it's severe and life-threatening as a non-disabled victim's experience, despite society's perceptions that disabled people don't suffer from a domestic abuse. Perpetrator is often disabled as well and uses their knowledge of the disability to control, isolate the victim. And that kind of runs in tandem where even with older people, people with disabilities, there will still, as in all domestic abuse situations, 9 out of 10 times there will be a primary perpetrator and a primary victim, and it's really important people remember that. And that's, I'll mention a bit about the counter-allegation work we're doing, but still it is rare to find one person that is as bad as each other. And I use that terminology because that's sometimes the terminology we hear in meetings and marrocks. And actually, if you have got two older people, if you have got two people who are disabled, chances are there will still be one primary perpetrator and one primary victim. And it's really important that people work with expert partners to try and identify that who is the main primary perpetrator and risk assess appropriately. And survivors with disabilities do not have equal access to support around domestic abuse that could allow them to leave the perpetrator safely. And if you kind of think about it, when I think about years ago working in services, managing services, you know, my heart sinks when I think about how completely inaccessible they were to people with disabilities. It makes me shudder, and you know, that's something that certainly we kind of hope to see improve, and there are some brilliant services that do have that now. I won't go through that because some of this I've already said, but just to say only 5.3% of victims at Marrick were recorded as disabled. So our national sort of what we expect to see is 18%. So 5.3% is very low. What I will ask Lauren again at some point, she will put in our guidance around how to record disability cases at Marrick, because sometimes it's not about necessarily not identifying, it's about how you then ask that person and record the information. So just before we go into a break, and I know that you will all have your own thoughts around this, so please feel free to put in the chat if over the next 3 slides you think that we have missed something out, because you will all come from your own experience. around barriers and the challenges that older people face. And one of the things I want to start with is just to read you out, which I think is really, really prevalent, a piece from the Lancet. And because I am almost 55, my eyesight is quite bad, and even with my glasses on, I'm probably going to struggle reading this, but I think it's really interesting. So they wrote a piece, and I can certainly, I can't get this to you in the chat, but there might be a way of us being able to kind of find the link to send you afterwards with the PowerPoint. So the Lancet were looking at how older people have been treated due to the pandemic. And as we know, that was another way of almost kind of pushing older people into the kind of sort of the back room again. We are, I would say, categorically still an ageist society, and it almost feels at times that that is one of the reasons why it's so challenging to get older people to disclose and kind of work with people, but people to identify them. And I think it's almost sometimes feel like a last bastion of actually you can still be ageist in society. And as we know, from amazing organisations from Age UK, older people, especially older people who are unwell, whether physically or mentally, or have disabilities, are hidden anyway. And so the pandemic came along and just kind of made that cohort of people even more hidden. And I think, interestingly, there's some amazing articles on how, even though people were appalled at the amount of deaths, which was, I think, in this country, 100,000, and I hope someone's probably going to correct me now and say that I'm completely wrong, but actually still majority of those people were older. And although people can accept that it was hideous and horrendous, there was also a sort of acceptance, well, at least it's not us. At least it's not younger people. At least it's not people who are under 40. And actually, what would the response have been then? Because there's still that element, even though I think if it's subconscious, that we don't know that we're doing it. We don't know that we're being judgmental, that actually, well, they were kind of at the end of their lives now. And if you think about the way that people were treated in care homes by the government when it first started, it is a bit like, well, they kind of had their time. This Lancet piece, I am going to read you out some. So it was done by the World Health Organization. And I think it's very beautifully written. So they talk about there is another even less recognized pandemic of violence, which it was worse than COVID-19. And actually those restrictions worsened in a way. And that's the pandemic of older abuse from their families. And even before the pandemic, elder abuse had been found to be shockingly common worldwide, with an estimated 1 in 6 old adults, 60 or older, the victim of familial abuse worldwide. Almost all these risk factors for elder abuse have been compounded by COVID-19 restrictions. So actually what had happened is that mandated age-based lockdowns or in shelters or care homes had imposed even more social isolation on older people. And therefore almost kind of it wasn't spreading the virus, but it wasn't without long-term harm. And actually it probably kind of increase that abuse, and Age UK has done some really interesting work on that. So one of the things I want to kind of read out as well is that one of the biggest problems driving that abuse was also a shocking public tolerance view. So Hourglass, which is a really, really good organisation, found in January 2021, there was a poll, and about a third of the British public did not perceive domestic violence against older people as abuse, with 49% of those polled believing that not attending to an old abuse need in a timely manner did not equate to abuse by a family member. And perhaps the most shocking disconnect is the fact that about 2/3 of reported abuse incidents had been perpetrated by more than one family members. And such tolerance probably arises from a widely entrenched attitude of ageism, which have also been uncovered or amplified by the pandemic. So in some ways, when I think about when we started this work 5 years ago, so 3-4 years ago before the pandemic, and we kind of thought it was improving, and then it kind of almost feels sort of frighteningly that it has gone back a step. And that's one of the reasons why we're restarting the work. And also on top of that, which I'll mention in a minute, what has then compounded it again is that going into a cost of living crisis. And there's a bit at the end that I'm going to, if there's time, I will read out because I think it's very beautifully written. So Think about the ageist society. Often we don't, I think also compounded that, often with domestic abuse, people also look at domestic abuse as having to have been people that are kind of within intimate relationships or sexual relationships. And I think often the other thing we do, which is ageist, we don't see older people as being in those sort of relationships. And I think therefore we often see, we kind of see them as not being able to kind of experience domestic abuse. So I think that's all tied up with it. There is from feedback from sort of authentic voice, so people who had experience of domestic abuse being older, that their perception was that services are for younger people. So we did a load of consultancy work with older people in South Wales a few years ago, and quite sadly and poignantly, a lot of especially the women would say, I don't want to take up spaces that young mothers need. They've got children. I don't want to waste their time. Those are the people that should be being seen, which is phenomenally moving. But that is also about how, you know, how can we create environments where older people don't feel like that? Generational, cultural, societal attitudes, I sort of mentioned that, and also those attitudes by those older people themselves. I mean, again, we don't want to end up almost stereotyping older people by thinking that all older people are like this, but there is still that generational, you know, you get married, it's for life, no matter what happens. You might have had no financial freedom before, or no kind of power of owning the kind of the family purse, and that actually you've made your bed and you lie in it. Family dynamics. I was talking to a service yesterday or Monday, Tuesday, and they kind of really reiterated this, that often if older people have got adult children, there can be that myth that they automatically think that those, or professionals think that those older children are going to support the parents. And often that is not the case. It is very common for adult children to actually support the perpetrator. And that's not being critical of them. That's about all those family dynamics which would have happened when they were younger. Health issues. At the very end, Nikki is going to kind of mention the new integrated health pathways, but this is massive. Loads and loads of health issues can be, it's really, really prevalent in older people. And that's why we kind of need to look at services working together, not in isolation. And health services are at that best point to identify people experiencing domestic abuse. Financial and socioeconomic abuse is very rife. Again, if people hadn't you know, people haven't ever kind of been financially independent. As we know, it's hard enough for young victims of domestic abuse to leave, and we know for all the reasons that you're more likely to be murdered. But if you've been in that relationship and in that house for 30, 40 years and your family don't know, you know, that having to kind of leave that is frightening. May not recognize their own experience of abuse. Actually, it's not abuse. I was kind of talking to people at the beginning of the week, you know, when we kind of look at that with the fact that in marital relationships, in marriage, that rape was only made illegal less than 20 years ago, I think that statistic still speaks volumes. So therefore, some of what people have lived with to them has been normal, and in some communities remains normal. Housing is a huge issue. Those who don't know, with the new Domestic Abuse Act and the kind of the money and the sort of the element of it that concentrates on looking at housing people more effectively, and for local authorities to take more responsibility of housing people, it's still really challenging if you have not lived on your own before and don't have that support to suddenly give everything up and live somewhere else if you're in your 70s, 80s. And isolation, that was a one that came up again and again and again when we did the Mentimeter. It's been pushed back again from being isolated anyway, going through COVID. We now have the cost of living crisis, much less likely to call 999, have the identification issues because of all I've just previously spoken about, and rather than DA services and police, people like health services, primary health, secondary health, hospitals, A&Es, adult safeguarding, adult social care are in an absolutely privileged position to be able to identify older people, work with them, and work in conjunction in a coordinated way with partner agencies and domestic abuse services. Cost of living crisis, again, it's another sort of thing on top of another thing to kind of help isolate older people. That, as I said earlier, is part of the reason we are starting this work again, because again, the people who it's affecting the most is certainly cohorts. I mean, obviously it's affecting across all age ranges, but certainly kind of older people. It's kind of creating that societal sort of situation where people are kind of in crisis and becoming more isolated. Increase in domestic homicide with older people. So I guess the flip side to that is that people are getting better identified, but certainly more domestic homicides are increasing that are around older people. When I say that, though, those are the, I guess those are the murders where it's clear cut that it was domestic abuse. Probably there's figures that are very different to that in reality, because also there are lots of kind of homicide that aren't then deemed as domestic homicide. So, for example, murder-suicide situations, which are more common as you go into the older age bracket. So I'm sure over the years, if some of you read particular kind of types of the media, the way things are reported. So not uncommon to hear of somebody murdering their partner because they were ill, they wanted to die, they couldn't do it themselves, so they wanted to put them out of their misery, and so took the life of their partner and then tried to die by suicide themselves, or the suicide didn't work and they ended up living. So some of those situations, there's lots of evidence to suggest that those aren't necessarily seen as domestic homicide. There can be, although I think things have shifted, but there can be still that reliance on that awful term around mercy killings. And it, you know, I don't want to go off on tangent because my colleague will throw a bit of paper on me, but if you look at how certain recent situations have been reported by the media, often certain things around the recent family in Epsom, you wouldn't even know it was domestic abuse killing because of some of the language. It was almost like a situation of, well, that was terrible that he'd lost his business, he couldn't cope anymore, so he murdered. So volume at Marrick, that has increased with older people, and that's really, really positive, really positive. But it means that we also have to make sure that we safety plan to the best of our ability. I just want to add terminology in terms of, often we use language that is quite disparaging around older people. So if my colleague here to my left, who I think is in her 30s, keeled over, we would talk about her having a fall or falling down. If she was in her 70s, we would probably say she was frail and had a fall. So it's that kind of language. Often you've got the issues around the carer role or the being cared for role. So actually, how do we work with our kind of our sort of partner agencies to kind of make sure that we are assessing individuals correctly and that we are not mistaking things like Alzheimer's and dementia for domestic abuse, and vice versa. And I will talk about sort of how we can sort of some documents we can help you to do that. And then disconnected communities, that actually we tend to live away from families now, and our communities tend to be much, much more disconnected. And counter allegations, I want to end on, I've just mentioned it earlier, but SafeLives are sort of currently doing some work around counter allegations, and that is around hearing an increase of there's 2 victims and there's 2 perpetrators, and that's quite concerning for us. So we're doing some work around sort of training packages and looking at guidance, because still mutual violence is very, very rare, and whatever's going on for someone, 9 out of 10 times there will be a primary perpetrator and a primary victim. Okay, I'm going to stop now for 5 minutes to let you have a quick breather, move away from your screen for 5 minutes. So if we can come back in 25 past to carry on with the rest of the session. Thank you. Hello, oops, welcome back, everybody. So that was my laptop moving very heavily. Welcome back, everybody. Hope those of you that have got your children at home today because of the strikes managed to have 5 minutes peace then, but probably not. So I'm just going to carry on just with another slide around barriers. So again, services may see person who harms as frail, which kind of links to often that kind of stereotyping around older people and older perpetrators. Again, I won't, the lack of the criminal justice intervention, mobility issues, and challenges around what is neurocognitive challenges and what is domestic abuse. Now, I have sort of mentioned that periodically, but however, what I do want to stress is that we, at the moment, there is more research starting now, and hopefully as sort of the work that we are going to kind of continue to do with expert partners, we can look at that, because it is incredibly challenging for any sort of partner agency to kind of look at what is neurocognitive and what is domestic abuse. However, what I will say, there is sort of lots of incidents where something has been recorded as someone's behavior as neurocognitive, but actually when assessment has been done, that actually it's come to light that there has been kind of history of domestic abuse in the past. So that I would definitely ask you to kind of remember that. But there will also be those challenges when that doesn't happen. What we would say, and I will kind of mention this now, and Lauren will put the spotlight link at the end, is that SafeLives kind of recommendations around working that with any risk is that somebody does that initial identification and contact either the adult safeguarding or IDFA services. And then what those two services need together is to mutually decide which is the more prevalent issue, or what at that point appears to be the more prevalent issue. Is it neurocognitive or is it domestic abuse? And then whichever lead issue it is, the IDFA or the safeguarding takes the lead with the other agency supporting them until it is devised as to what that particular prevalent issue might be, or they continue to work together, because as we know, that is best practice, working together. And actually it's one of the only incidents in the MARIC world where we do recommend that once it's decided what that issue is, and you have those two services, one of them taking the lead, that actually a professionals meeting is held before a MARIC or before a kind of medium risk meeting to actually kind of see how to work with someone. Health services, primary care challenges, harder to access appointments and visits. I think, again, that has been phenomenally compounded in the cost of living crisis and also the health service crisis going on at the moment. And I know, just so I know, Nikki talked a bit about her own experiences at the beginning, and just to kind of give a tiny minute of my current background, I have a father who is very unwell in his 90s and needs a lot of care from carers, and my mum is 84, phenomenally healthy, fit, sprightly, and really together. But even for someone in her position, she's finding it tough. And I was absolutely stunned to hear that in their kind of local primary care surgery, GP surgery, she's only, when she rings, because she's worried and frightened for my dad, she's only allowed to ask one question about one issue. And if you think about it, she's 84 now and also has other issues herself, she's only allowed to ask one question on one particular issue from my mum and dad. So I think if that's hard enough for my mum, who's very kind of with it and on it, gosh, for people who are older and aren't, and who don't have the support of supported children, I think and who are in a domestic abuse situation, just must be horrifying. So increase in risk escalation due to cost of living crisis and health challenges I mentioned. Discharge plans implemented with a lack of coordination. This was when we did this work originally. What we did is that we did a load of case audits around older people with police forces and partner agent forces. And this was one of the most common things that came out of it, that there might have been services working with the victim before the perpetrator went into hospital, but then the perpetrator went to hospital and there was just this breakdown of communication. So even with the best will in the world, hospitals and services and care homes were sending perpetrators home and back into that being in that situation where they're the abuser or the victim going back into the home. And it was that kind of, we still see in domestic homicides, too little relevant information was shared or coordinated work, and that is what is happening with discharge plans. And even, we had stories of saying, oh, the victim can come and pick his stuff up, it doesn't matter. So that, we need to kind of start working on how we can support services to improve that. There you go. I'm not giving you another 5-minute break, just I gave you one a bit earlier. I wanted to just highlight this slide from the brilliant Standing Together national charity and their kind of expertise around domestic homicide reviews. I would also ask you to go onto their brilliant website if you want to read more about their work. They took out 30 specific reviews, and some of the themes and the resulting kind of recommendations, that is that all agencies have a role in identifying, responding to domestic violence. So important. When Nikki kind of talked about Safe Lives, the work that our team does around public health, that is really the core of it, that we are no longer saying this is not just DA services and police, we all are accountable to trying to end it. Also, professionals made assumptions that older people don't experience domestic violence when displaying signs and symptoms of abuse. Over 1/4 of those killed by a current partner were aged 58 plus. And professionals assume that younger current partners were their carers and not a domestic violence relationship. I think this, and again, this is anecdotal, but I think this is really prevalent in same-sex relationships as well. That is very, very common, especially around kind of men, that people assume that situation. And 6 domestic homicide cases revealed the perpetrator was their carer, and yet no carers assessments were ever completed. And for those of you that have ever tried to get carers assessment, I have had one good experience of it, and there are some brilliant, but it can also be phenomenally challenging, especially if you don't have supportive family, or it is members of your family that are being abusive. So just to link on to Marek. So there are 9 core agencies that Safe Lives recommend need to be at Marek at every meeting and to stay the entirety of the meeting. 2 of those are absolutely vital. And when you get good in terms of older people's abuse, and that's health and adult safeguarding or social care. So they are core agencies we expect to see at Marek on a consistent basis, because those are the agencies that are more likely to A, be identifying older people, B, be able to work with older people going forward, and to be able to kind of be a really integral part of that action plan with the IDFA. So that's really important. The other thing that you will find in the link to the spotlights that's going to be put in the chat is that we also did a care pathway template between adult safeguarding, health, and the IDFA. And it's a template where you can kind of come in and put your own sort of local pathways on it, or what you want your local pathways to be in terms of assessment of older people, Marek, and IDFA, and adult safeguarding and health. And then there's also a document on guidance of adult safeguarding boards working with Marek governance board. So that's really important. The governance at the Marek should involve adult safeguarding directorship and health. So actually you should automatically have good governance, which then supports the operational practice of the Marek to ensure that everyone is doing everything they can around that table. I just wanted to add this. I'm sure there are people in this room that know this way better than me and know at the back of their hand. But one of the reasons adult safeguarding was the last core agency we added to the Marek list. And we did that because of the changes in the Wellbeing Act in Wales in 2014 and the Care Act in England. What I would absolutely emphasize, though, is that I think something that did happen is that it sort of got a little bit into Marek's would saying, Safe Lives say that adult safeguarding should be here now, so can you come? And adult safeguarding said, well, we will come, but we can't see everyone. And so I think a bit of a chasm kind of came about. And what I would ask is that you just ensure that IDFAs and domestic abuse services really understand what adult safeguarding's criteria is, because although those changes were made to the Care Act, which was really great, we had to kind of work with people who have primary domestic abuse issues, there is still criteria for that. And I think sometimes that can be missed. So on the older people's accredited course, we have a whole day of training around adult safe criteria. And actually it's been really, really useful for IDVAs, because they've gone away thinking, oh, actually, now I do really know what I can ask for and not ask for. So I would really kind of emphasize that kind of championing and learning between those partners, merit partners, and safeguarding is carried out. I just added this slide in around MARAC. So if we just look specifically at disability, which obviously we're linking to older people, is that the recommendation, and I said 18%, and I've just realized it's gone up to 21%. So actually we're expecting kind of higher identification, but in the last year, in the rolling year, October 21st, September 2nd, it was 8.5. So there's still a long way to go. But like I say, although it is increasing, that's really, really positive. We would ask you to kind of look at, ensure that you are kind of actually not making assumptions as to about who is disabled and not disabled, and the guidance will hopefully help with that. When we look at MARAC referrals, like I say, adult safeguarding is 0.8 now. It definitely needs to be higher. And then if you kind of go to primary care, it's 1.8%, and secondary care 2.3%. So again, we would ask in your local MARAC areas that you can ask your MARACs for the data, and your governance group should be monitoring this data and finding out how they can increase health and adult safeguarding referrals into the process, and to make it as easy and as straightforward for those agencies to refer in and to make those pathways clear. Sometimes MARACs will say to us, oh, pathways are really clear in that area, and yet if I was to be an adult safeguarding lead or I worked in primary care, they wouldn't be clear to me at all. So it's good for areas to review that. So I'm going to move on now to the last bit that I'm going to talk about, which was some of the policy and practice recommendations that came out of the work. And hopefully when we begin the second phase of the work over the next 3 months, we will then build on this and then hopefully be able to share this on another platform again when it's finished. So we talked about systematic invisibility, long-term abuse and dependency issues, and increased risk of adult family abuse, and that services are not always effectively targeted at older victims. So that also needs to be looked at by commissioners. And then generational attitudes about abuse make it hard to identify. And one of the kind of the biggest things is that there needs to be greater coordination between services. In-depth face-to-face training for health professionals, social workers, care workers, and council staff, regularly in contact with older people, accompanied by domestic abuse champion programs and adult services to ensure the learning is continued and new best practices be communicated. And just to add to that, that isn't us saying everyone's got to go out and fork out tons of money and also kind of time to have training. There are lots of domestic abuse agencies around country that do one-day sessions. There's lots of information on websites such as SafeLives, such as local authority websites, and like I say, there's amazing organisations like Age UK, Jewish Choices, and Hourglass that kind of have a lot of that information. But it is about not necessarily making people experts, but making people aware of what to look for, how to identify, how to refer in, and how to also get that expert advice. Ensuring that contracts for provision of domestic abuse support recognise that older victims may need prolonged interventions due to their abuse and potentially desire not to leave the family home. That kind of fits really with that kind of increase over the last few years of domestic abuse services no longer feeling that the be all and end all is that expectation that somebody will leave, because actually we know the reality, whatever age, that just might not happen. And there's a huge kind of push, especially the last few years of, you know, working with those that harm, that actually combined all those services working together, that people can to a certain extent be worked with to remain in the family home if that is what they desire. And then provision of specialist domestic abuse services in a health setting, which we've talked about. Effective safety planning on the discharge, I've spoken about that, to ensure that they aren't returned to an abusive situation. And sometimes this is as simple as people communicating the situation, or being able to identify that situation in hospital if it hasn't already been identified, raising awareness of domestic abuse among older people, and ensuring that services are targeted to places older people will see. Example, GP surgeries, public transport. I know at one point a few years ago, there was amazing work done in South Wales in the valleys where people, serviced IDVAs or domestic abuse workers would specifically just go and sit in places where, certainly in that community, people would be more likely to be. So local community centres, also in community and faith centres and religion centres, and GP surgeries, and would just hang around, as brilliant IDVAs do. And like I say, places like kind of public transport, but certainly health settings and adult safeguarding settings are really important. Training for domestic abuse professionals into family violence and safeguarding issues around older people. And like I say, kind of saying that kind of joint sharing of knowledge between health agencies, adult safeguarding agencies and domestic abuse agencies, to try and do that identification together to try and help in terms of which is the prevalent issue. Consulting older victims as part of service redesign, such as housing and refuge options. And as we know now, there's a real push within the DA field in terms of involving the authentic voice. So to actually listen to what older survivors are saying to us about what would help them now and what would have helped them in the past. That's the only way that we can move forward. And also making that input not tokenism. So in the public health work that we do, which Nikki talked about, that authentic voice is actually first and foremost at the centre, and our recommendations are always around them influencing policy and kind of sitting on boards and being kind of proactive and not just being that kind of tokenistic voice. Embedding adult safeguarding social care as a core MARIC agency. I say that because I would say it's very rare for us now to not go to America and not see health. They were the original core agency 20 odd years ago. But adult safeguarding and social care, we appreciate it can be challenging. But please, please, please contact SafeLives, because we are really happy to come and do talks to adult safeguarding boards or do sessions on why it's important. We kind of really help getting my words twisted, help to kind of support you with that. And then adult safeguarding boards and health boards should also monitor referrals of older victims to domestic abuse services, and also the MARIC governance board should be doing that. And like I say, your MARIC should have a director of adult safeguarding on that board anyway. And then health needs to look at identification of older people and referrals into service, and again, coordinated work with specialist services. MARIC, IDVA and adult safeguarding, I've already mentioned that. They're the templates and the documents that are going to be in the spotlights link at the end, and the care pathway template. MARIC data, again, I would, slightly different to what I've just said. I don't think enough people involved in MARIC are accessing their data from SafeLives. And if you feel that you would like to do that, I would contact your local MARIC or contact our MARIC team, and I will get Sarah or Lauren to put the details in, and we can see about giving you access to the MARIC data. Your MARIC governance group should be looking at all of your MARIC data. They should be performance managing what goes on in the MARIC. Survivor voice, I've mentioned, absolutely at the heart of everything. There's a recognition now we can only improve services if we have that proper survivor voice and input. And like I mentioned, the Older People's Commission for Wales has done some amazing work around consulting older people as part of that, and they have some amazing kind of videos on their website about some of the changes that happened. And yes, the local adult safeguarding board document that I mentioned earlier. So going forward, so before we go to the last Mentimeter, and then I hand over to Nikki. I've mentioned some of the work. Hopefully, we're going to be building on this work, but hopefully, what that will include is working with our expert partners around that, and continue to do so. If you've listened to this webinar and you just think, God, I really, really want to get involved, and you can drop us a line. It will be also concentrated on, I guess, looking through the aftermath of the pandemic and also the current cost of living work. So we are doing that at the same time in parallel at SafeLives, and older people will be a big part of that. As part of the original work we did 5-6 years ago, I was funded by the Home Office to write a 4-day accredited course responding to domestic abuse of older people. We ran that across the UK, it was funded. It does now sit as a course that can be commissioned. So certainly what we're going to do is to refresh that, I guess, start marketing it again, but also seeing if we can separate it out into separate sessions so people don't feel they need to do a 4-day course, but that accredited course is still there. We're going to write guidance, we're going to write blogs, we're going to include the authentic voice, and we're going to look at diverse populations' experience of domestic abuse. And also, more importantly, have a look at, have a visit, and kind of build on some of the most amazing work out there. So I know since the course, there is now more editors that are specialising in older people's work. So I know that there's some amazing work that goes on in the Midlands around working with older people in domestic abuse settings and older people's editor specialists. So we will kind of look at that work as well. So that's brilliant. I'm now going to go back to the last Mentimeter. So I'm going to stop sharing my screen in a second, but I'm going to ask my colleague to bring the question up, but it's basically ending on sort of going forward, what else would you like to see happen for older people in terms of domestic abuse? Because from your ideas, it might be that we can then incorporate that in the work we do forward. So I'm going to stop sharing my screen so that my colleague Sarah can bring up the Mentimeter. And it's the same link as before. So you're doing exactly the same as when you came in at the start of the session, but with a different question. Yes, health DA advocates, I think that's, yeah, because we often, I think the sort of champions and advocates thing, when I started at SafeLives, it was a real emphasis on that. But I think as funding changed, it was less, but I've noticed that there's a real push to start bringing champions back into health settings and safeguarding, which is just amazing. Yeah, taken seriously and listened to, absolutely. More integration into social, yeah, brilliant. More support. Special advice, yeah, financial stuff. There's some really great work that is happening around socioeconomic abuse as well from particular areas. More supported housing, absolutely, absolutely. Listen to them, champion roles for IDVA, yeah. Training, yeah. Emphasis on education, definitely. Because sometimes that's all we're asking from people. We're not expecting people who've already got phenomenal busy lives where DA isn't their core work. It's an awareness of being able to kind of be aware of when somebody might be needing help and support. Yeah, more places for older people to meet and spend time. Definitely. Definitely. I just think that just completely disappeared in COVID. And the risk is that that's happening now in the cost of living. Yeah, a routine of visiting professionals to see personal loans part of the visit. It is, I mean, this might not surprise many of you, but it is quite amazing still how many professionals will ask a potential survivor of domestic abuse or someone who's going through domestic abuse while the person, the family member or the person who harmed is in the room with them. So it is about awareness, challenging stereotypes of older people. Absolutely. Absolutely. And the piece in the Lancet at the end actually does talk about that we need to start making older people more human because we're all going to get old. It all happens to us. Education for GPs, yeah. More specialist support, yeah. More dementia awareness when it's related to DA, definitely. Yeah, technology is a massive one. I think as the whole, I mean, that was nothing about COVID and the cost of living crisis. People get isolated. I think kind of younger people have access to technology and how to use it. Which I think with older people, that's again another barrier. Having said that, we know that some people can use it really, really well. In fact, I've got some friends in their 70s that can use it better than me. But I think generally, it's another barrier for people. And digital inclusion, that's quite a nice term for it. So I've just seen that question. There isn't an older person's RIC. There is the SafeLives RIC. But what you can do is put links to things like Spotlight so that when people are completing it, they can kind of think about stuff. We are at the very beginning of a review of the RIC, and it will take a long time, but it might be that out of that we look at different cohorts of people. Okay, so I'm going to share my screen again. Right, so there's kind of information around SafeLives. What I'm going to do now, after that, thank you for all of those ideas, and we'll definitely add them to a list as the work carries on. So very finally, thank you to listening to me. I know it's quite, it's an intense hour and a half, but I'm going to hand over to end the session to Nikki Kelly.